Thank you very much, and greetings to honorable members of the portfolio. And thank you for coming, as well as the officials. Welcome the MEC of Health and your team. For sure, you didn't fire anyone. They used to sit until that seat and at your back. Of course, that was in a lighter note. The point is, welcome you to the portfolio committee meeting. I hope you are enjoying the winter. Some of us here, we have a problem with it. But welcome to the portfolio committee this morning. And of course, it's Friday, the 19th of June. And we will be live on our live stream. And please be aware of that. And yeah, thank you very much. We have put the agenda just in front there for all of us to see. It is extremely short. Of course, we also wish that our ways are equal to the duration of the session. We will be dealing with the annual performance plan and budget 2026-2027, as was presented by the MEC. We, all of us, will not be seeing for the first time like you. And yeah. But without much ado, before we go to the substantive matters, we will deal with item number 2. We'll start with ourselves. Of course, we didn't put introduction because we know each other. Except that we have 1 or 2 people in our side. And I'm not always right with this, now always contested when I say we know each other. But let's deal with the roll call and apology. Check if everyone who's supposed to be here is here. And if we have to dismiss somebody, let's do it. Let's start with ourselves.
Thank you, Chairperson, and good morning. Chair, I've received an apology from Honorable Libya. She's on sick leave. The second apology is from Honorable Leboha. And the last apology is from the committee coordinator, Me Masete Lerato. Thank you, Chairperson.
Thank you, Honorable Chair. Good morning to yourself and honorable members of the Portfolio Committee and all the officials who are present here. Chair, the apology is from the 2 DDGs. One is not feeling well and the other one is representing the department on the other commitment. But also, Chair, I know we've started early, but should it happen that the meeting runs until 1 o'clock, I will request to be excused because I need to go and receive a memorandum from one of the unions.
Okay. And we are going to refuse your recusal and say to you, go even if we don't want to. We also wish so that we must end before that time. But your apology is noted. We wish not to deal with it. Yeah. Okay. I'm advised that these people that I'm saying they are new, they are known to you, they are only new to us. So, if I'm right, we will call on the MEC to present the 2026 and 2027 financial year annual performance plan and the budget.
Thank you very much, Honorable Chairperson. I will hand over to HOD for the presentation. Thank you.
Thank you, Honorable Chair, honorable members. Dr. Lekulane will take us through the summary of the APP and the budget for 2026-2027 financial year. That's our planner. Thank you.
To the executive in the department, good morning, Chair, and good morning to the members of the committee. My name is Dr. Lekulane. I'll be taking us through the presentation. That projected there is the outline of the presentation. It will just be arranged by program so that we orientate ourselves, and then we also note that this is a summary of the budget that has been and the APP that has been presented at legislature. Next slide. This here just indicates to us that will be the first full year of implementation of the 7th administration, and then the alignment remains with the MTDP and also the Limpopo Development Plan. And then on a high level, the overall budget has increased by 10% from the 2025-26 main appropriation, but by 7.9% from the adjusted appropriation. And then there were increases and decreases with regards to the conditional grants, and then the decreases were seen in the National Tertiary Services Grant, while the increases were in the Comprehensive HIV and Health Facility Revitalization Grant. Next slide. So here we are just indicating how we come to the APP to say that the National Department of Health coordinates for the sector, and then we have a series of engagements where sector indicators are decided upon, and then these are then sent to the DPME once all signed off by all the HODs in the provinces, and then the DPME then sends to the offices of the Premier, and then we are then sent that list so that we can ensure that it's captured in the APPs. And then this year we'll be tracking about 58 indicators that are in the APP. Next slide. This is again the overall departmental budget summary and budget growth from the previous financial year, which, as indicated before, it is 10% from the main appropriation and 7.9% from the adjusted appropriation. And then there are decreases and increases per program, but I think that is the overall, and then we will go deeper into the each program and what it entails. But for now, that is the 10% increase and the 7.9% from the adjusted growth. That is the overall, and then below is the breakdown by economic classification. Thank you. Next. So starting with Program 1, which deals with strategic management and overall administration of the department. The budget allocated there is 309.1 million, and there hasn't, it has just decreased slightly from the previous one. We can go to the next slide. And the indicators then that are covered under Program 1, the first four are the ones that we usually track, the audit outcome, and then with the annual target there to maintain the unqualified audit, and then payment of suppliers within 30 days and completeness, and then revenue collection. These are the usual indicators that we track, and then the budget as indicated. Next slide. We have added these indicators that are the first three are the procurement targets, and then the last three there at the bottom are the employment equity targets, Chair. So in terms of the procurement targets, we are looking at black participation, black-owned businesses 40%, and then women-owned at 20%, and then disabled-owned at 0.5%. And then also in terms of employment equity, the women at FSMS, we're looking at 45%, people with persons with disabilities 0.7, and then the youth in development activities at 600. These are our learners and and so forth. So this is the budget and the budget breakdown, as indicated that it is at 309.1. Next slide. So as now we move to the programs and the facilities and the platforms that we operate on, the top map, it just maps our facilities across the province, and then the table then just gives us the numbers with regard to the different platforms that we operate on. Next slide. And so this is a pictorial depiction of those platforms. The pyramid at the bottom, the primary health care is our biggest platform, hence it is the foundation for everything. And then as we go down, go up, then we have district, regional, and tertiary. And then if you can just do the next, you can press maybe 4 times, next. So on my right, we see that these are the teams that are leading those platforms, or they are predominantly responsible for those platforms. And on my left, which is very important, is that we have administrative support and administrative services, and then the programs. To just make sure that we understand that the programs run on all the platforms. A patient can attend to 2 or even more platforms, even in one day. So there are those overlaps and linkages that happen in the department. Thank you very much. Next slide. Next one. So starting with the district health services, this is our biggest program. It carries about 2/3 of the budget, and then it is broken down by those platforms that I have indicated, community services, all the way to nutrition services. And then maybe just indicating also that the nutrition services, it's one of those programs that run across all the programs, much as it's in program 2, it ran across. But then the budget has been allocated according to all those levels and programs. Next slide. So the primary health care, that foundation, that is the biggest platform, has these indicators that we'll be tracking. But these indicators are not, the first 3 are not peculiar to the primary health care, because in all our facilities, these are the things that we measure. We measure patient experience of care survey rate. We measure patient safety incidents, case closure rate, and then we also measure the ideal status obtained. So for all our facilities, we will be measuring those, and then these are the targets that have been put. We want to make sure that they are there. And then given the issue of mental health, we added an indicator on mental health conditions treatment rate new at this level, so that our people are screened. And next, the district hospitals, as indicated, the indicators follow the same pattern: patient experience of care, patient safety incidents, and also ideal status obtained. So the ideal hospital status obtained for district hospitals, and then that is the budget allocated for that, and then all the other programs run there. Next slide. This is the HIV program, still in program 2. We want to reduce the number of people who are tested positive in the first 2 indicators divided by age group, and then otherwise the indicators are the ones that we usually track even in the previous years, and then that's the conditional grant allocation for the HIV program. Next slide. And then the TB program as well, we have indicators that we want to make sure that all the people that are diagnosed started on treatment, and then we want to test as many people as possible. So we increase the number of tests, and then we also make sure that with regard to malaria, very few of the people that are diagnosed actually died. So the budget there for malaria is 562 million. Next slide. And then maternal and child, we have indicators. These are indicators that we usually track. And then we have maternal mortality in facility, couple year protection, and antenatal care. And then we have also indicated the annual targets, and those targets, we usually track them quarterly, and then we try to make sure that we remain under those targets even as we build up to the annual. So it's mainly about mothers who are pregnant, and then also children who are in our facilities, neonatal deaths there, and then deaths under 5 against live births. We want to keep it under 2%. And next slide. Continuing with the maternal and child, we have a malnutrition case fatality rate. We're still struggling with this one because it is mainly outside of things. It relies on things that are outside of our influence in the community largely, but we collaborate. And then we have immunization and measles and rubella dose, first, second dose coverage. Those are the targets. Infants PCR, we want to make sure that those are achieved. And then we are going to be screening grade R learners, and at the end of the year we're looking at 38,000, and then cervical cancer screening coverage at 40%. Next slide. And then this is the overall budget. We mentioned that it is 19.3 billion. And then they saw an increase of 11.7% from the main growth and 11.1% from the appropriated. And then program 3, it's about the rendering of emergency medical services, including special operations and ambulance services, and then also the planned patient transport and pre-hospital and inter-facility transfers, and then it has been allocated 1.3 billion. Next slide. And then these are the indicators that we'll be tracking. We want to keep the response rate for both urban and rural response at above 90%. And then we also in this, we have program 4A, which is about our specialized, mainly mental health. We're also tracking the patient experience of care survey rate and the safety incidents, and it's 60 days. So those are the ones that we will be tracking in those hospitals. Next slide. And then this is just to indicate that budget and the adjustment that has been made from the previous financial year, and the budget breakdown by economic classification. Next slide. Program 4, regional and which is regional and specialized. It is for the delivery of hospital services, including specialized psychiatric or mental hospitals and rehabilitation services. And then the budget allocated there is 3.3 billion. And then the breakdown is by regional hospital, psychiatric, and then TB hospital there. Next slide. And then this is the indicators these are the indicators that we'll be tracking for the regional hospitals. The first 3 are the usual ones that we track per platform, per level of care, and then the experience of care and that. And then the last 2 were brought in because of the gender-based violence scourge that we have here, to say when patients come to our facilities, what are we tracking to make sure that we do take care of them, and then we have make sure that everybody has the forms filled, and they also get the care they need in that regard. Next slide. And this is the budget and the budget breakdown, and also the budget growth that we are seeing from that 3.3 billion budget for program 4. Next slide. And then with regard to tertiary, these are the tertiary health services, and then this is where training of health workers occur, and then and also the rendering of highly specialized healthcare services. So the budget allocated there is 2.5 billion. And next slide. And then these are the indicators that we are tracking. As indicated, patient experience of care, patient safety incidents, and ideal hospital status obtained rate. At the back of our mind, we know that all the programs that are run in the department, they also run also on this platform. Next slide. And this is the budget breakdown of the 2.5 billion. Firstly, by budget growth, 5.6 from the main, and then 0.8 from the adjusted growth, and also the breakdown by economic classification at the bottom. Next slide. Program 6. These are the health sciences and training services where we provide training and development opportunities for the actual and the potential employees. And then we have the allocations below there with regard to bursaries and nursing training colleges, and then health professions training, and also EMS training. And the next slide is that we are tracking the nursing mainly as our indicator, and we're targeting 200, and then with a budget of 679 million. And then this is the breakdown according to those programs that have been indicated before, and then and with the breakdown and the budget growth indication on the right. Next slide. Program 7. We have we render support services as required to deal with the issues of rehabilitation, but then the programs involved include forensic services, rehabilitation services, and also medicine supply. And then the budget there is 248 million. And next slide. We then will be tracking mainly our medicine availability, which we are targeting at depot level at 78%, and the hospitals at 83%, and then at primary health care at 82%. And then we're also looking to enroll patients on the centralized chronic medicine dispensing and distribution program. And we are hoping to or planning to enroll 35,000 of those through that budget. Next slide. And this is how the budget has been broken down by the rehabilitation, forensic, and the medicine account. You can see the biggest growth is in the medicine account there. Next slide. This is the last program, Program 8, Health Facilities Management. For planning, equipping new facilities, and upgrading, rehabilitation, and maintenance of our facilities. The budget allocation there is 1 billion. Next slide. And then that is the indicator. So we will be tracking projects, the number of completed maintenance, repair, and refurbishment projects. We're planning to deal with about 350 of those projects through that 1 billion rand allocation. And this is the budget, the 1 billion, this is the breakdown of the budget. As you can see, it is divided according to the different platforms, the community, the district, and the provincial and tertiary hospitals. And then we have seen that it has grown from the main appropriation, but then there is a reduction when we look at the adjusted appropriation. So in summary, with regard to the budget, we indicated that we had a 10% budget growth from the 2025-2026 main appropriation, but then with regard to the adjusted appropriation, we are at 7.9, and then that is the below is the breakdown by economic classification. And the last slide, this is the equitable share. The equitable share has grown by 11.3 for the main appropriation and 9.1 for the adjusted appropriation from the previous financial year. And the economic classification, these are the conditional grants, slight increase of 1.4 from the adjusted appropriation. The total there is 4.3 billion for the combined grants. And then, yes. Thank you, Chair, and thank you, Judy.
Yeah, I appreciate the presentation, MEC, so you know that it's not going to waste time. Thank you so much. That's although it took short time, but that was a comprehensive presentation. And thank you. MEC, do you want to say something before I open the floor to honorable members? Fine. Okay. Thank you very much. Honorable Ngoyan, I did not see that you are here. Yeah, I didn't. I thought you and him were connected by blood and I was supposed to hear it from here. Thank you very much. Well, it's just, I'm happy to see you and don't have a problem with me when I said your name and not said all others' name. Yeah, honorable members, that's the presentation. The floor is open for you if there is any matters of engagement that you want to, particularly the clarity seeking question, because this is their plan for the year, which include the budget. So I'm going to start with Honorable Mutaka.
Questions and greetings, Honorable MEC and the HOD and all directors that are present in today's meeting. And we'd like to appreciate the business-like type of presentation of the APPs. And I wish that is what our patients can experience when they go to a hospital and they go in and they go out quickly after having received the service instead of waiting there for a long time. So that shows that we have people who can really do things properly here. And if that improvement can go to the hospitals themselves. Yeah. Thank you very much. First and foremost, I want to go straight. I've seen the budget is 28 billion, all right, 684 and 080.79. That is the figure. And I've seen that you've budgeted for different categories of programs. The one that I'm interested in is the one that deals with clinics. One, I think the Premier pronounced that there will be a building of new clinics, if I'm not mistaken. I was in that State of the Province address, and I was very excited because even where I come from, there's no clinic. So I felt that one will directly benefit with this new program, because I remember very well in 1994, I was in the RDB Commission and we approved 477, if I'm not mistaken, clinics that were supposed to be built in the province, if not 457. I'm not more sure of the exact figure. And since then, I've never heard of a new clinic being built. Well, maybe I'm wrong. Maybe I was not following, properly. And we have district clinics, district centers, what do you call it? Health centers, community health centers as well. So I've seen that in your budget, the money for the health centers are quite low. I used to visit health centers in the past because I would be taking patients there myself as a ward counselor. And now, I did visit the district health center at my place at Bungeni when I took my brother there. And I'm not sure if the services are still the same. When I look at them, I feel that they've gone down. When I look at the district, the health center then and now, I feel that the health centers are being neglected. And I can see it in the budget here that the health center's budget is quite low. It's below R1 billion. I'm not more sure of the figure, whether it was 700 and something million or what, or 800 and something million, but at least it's below R1 billion. Maybe it might be because of the number of the district health centers vis-a-vis the number of the provincial health centers, which is also a particular number, but the money is at 19 billion for the hospitals in the province. And my understanding is that the health centers are a mini hospital of some sort in a particular community, where we must also try and concentrate so that we deal with health matters there before they come to the hospital itself. Because my understanding is that even doctors are deployed in the health centers, so that they then act as a mini hospital, and they must also get a good budget. For one, when you enter the health center, you must feel healthy immediately, even before you are touched by the surrounding around you, because it also contributes to feel very much welcome, and that I will go out of this place healed because of this, because of the way the health center looks and how it is maintained and so on. So I think we need to respond to that, because yeah, we can have more money in provincial hospitals and so on, and where the operations are happening, but then also at the health centers, I think there's a need for us to really concentrate on that. So that's, I'm asking a question, but at the same time motivating why the money is low. But then the real one is, do we have new clinics that we're going to build this financial year? Because I didn't see them here. Maybe they are hidden somewhere in your APPs, because definitely you need to deal with that program. And the other one that I'm interested at is the issue of how can I put it? We have seen that you've actually put money for the renovations, or I will put it renovation. You have got a way of saying it, rehabilitation of hospitals like Maputa Tab and so on, buying of, dealing with issues of X-rays and so on and whatever. And it is there, but my understanding is that that work has been done sometimes. Maybe it's because you said for hospitals like, so that we understand that you're doing it like that. I'm also providing an answer, but I want to know, why is Maputa Chava still there when we have actually seen it being, is it rehabilitation? Yes, I don't know the right word. So that is another one. And my last one is where we went in Luwahomu. You also put money for those issues, buying furniture for Luwahomu EMS. And when we went there, the EMS in the Luwahomu has been abandoned. The building is not complete. So how can you buy furniture when there is no building? The building itself is not complete. And maybe you should also update us, if possible, in terms of that EMS. We only saw the security guards there. There was no single ambulance. The ones that we saw there could not move. I think they are just, cars that could not. They're actually damaged. They can't move. So we just want to be updated on that. And maybe the other critical one is when we went to Malamlele, for instance, in EMS there, we only saw that there are very few people, or maybe one or two, I'm not sure the number now, of people with advanced life support. And in many EMS centers, whether it is in Mudimule or wherever, maybe Mudimule was better, I'm not sure, but advanced people with advanced life support are very few, and I see that you have a plan to recruit them, and we need just more clarity on that one. Can I still ask the last one? Maybe let me leave the rest for the others. If they don't ask, then I'll come back.
If they have questions, because they may not have, you can ask that last one. Don't raise hands, honorable members. I'm just going to give you a chance. You done? Okay. Honorable Ngoyan.
Thanks very much, Chairperson, and greetings to the team, yourself, members. Chairperson, I don't have a question necessarily. I have a concern, and it is a concern that now for a number of times I've been in and outside the meeting, discuss it with the CFO, discuss it with other people from the department. The issue of Program 8, which deals with your infrastructure. Now, I note that the allocation for the program stands at about R1 billion, if I have read well. Yeah, it's 1 billion straight square. And The money that you put aside vis-a-vis the need, the overall infrastructural need and backlogs of the department, that's my main concern. In the previous financial year, they might have reached their target as anticipated, or they might have had a smaller backlog before reaching the target. But the actual physical and visible output, you still have a challenge there. There's a serious backlog there. On paper and somewhere in the corners it has happened, but the status remains the same. There are some facilities where you will see progress, of course, but predominantly and mainly, we still have a challenge of the aging old infrastructure across the country, not only in the province. But our own role as a Department of Health in Limpopo must be seen, Chairperson. It must be seen, it must be felt. The MEC has pronounced on, including the Premier, they've pronounced on key projects that will be outrolled this year, including the reconstruction, let me put it correctly, reconstruction of Chiridzini Hospital. I'm not sure of the old one, but they've said there will be a reconstruction, not a revamp. The Premier said, and the MEC, reconstructing a new modern style Chiridzini Hospital, which is long overdue. And want to welcome that, and want to applaud that. But as a baseline, Chairperson, because this is a concern, not necessarily a question, as a baseline, if we can target these clinics, target these hospitals mainly, and deal with the issue of these entrances, the vegetation, the normal paving, these normal things, they really assist in uplifting an image of an institution. Sometimes they say cleanliness is next to godliness. Chairperson might not know because he's a communist, but us who are Christians know and understand that cleanliness is next to godliness. And people tend to associate good service with cleanliness. They tend to do that. So, deliberately so, Chairperson, I would pursue and lobby the department to say, CFO, can you put some funds aside? Dedicate a particular portion of the budget with what we proposed last year. And I want to remind you, last year we proposed that, how about you develop a 3-year framework or a 3-year program? Being the first year, you target empowerment or employment of contracted workers, EPWP if you like, that will assist you. But I've seen that you've done that. But the second part, I'm waiting for it. I look at you, CFO. I think I look at the MEC also to say, as a start, employ them as EPWP, but with an intention to absorb them piece by piece, year by year, permanent. I'm looping you. I'm looping you because really, we must be a transformative administrative, must be rapid and radical in addressing some of these issues of unemployment. And we cannot have this over-reliance on EPWP. We must be seen doing something. We have done very well in employing medical practitioners, your professionals. You've done very well, and you must be applauded in that space. You've done well so far with the little resource that you have in training professionals. But what about the people that must take care of your institutions? The ordinary cleaner who cleans a ward, the ordinary gardener who trims the trees and prunes them, the ordinary man who can sweep off this dust in our entrances. What do you say about them? But on the last point, Chair, because I said I will not ask a question, I'll be raising concerns. The last concern that I have before summer is that don't you have appetite as a department, having experienced difficulty this year, transitioning from the old contractor to new contractors in security services? Don't you have an appetite to, perhaps in phases, start absorbing these security personnel permanently? Don't you have an appetite to perhaps conduct a study on the pros and cons, the goods and the bads, of contracting them or employing them full-time? In phases, DDG, not once off. I know it can be a very long process. But in summary, the department came to the portfolio committee to present their APP and budget for the 2026 financial year, setting their own targets. We're not there. They came to us, said, we're going to do this until that for the next 12 months or for the next 4 quarters. I take it that it's them because I've seen the actual APP. It has around 10, if not 12 signatures. So it means it was a process, a very lengthy process. Nako dia say, nako dia say, nako dia sign a more, sign our sign, until all of you signed and agreed that we are putting up APP, we are putting up a budget. It's your plan and how we are going to execute it and the man that we are going to use to execute the plan. It's yours. We are owning it. Now, Chair, I can first quarter, second quarter, third quarter, and the last quarter. It's you who came to us and said, this is what we're going to do. When you feel, or because you deal with tracking of your own plans, when you feel or you think or you see, no, we're told the public, because this is a public meeting, we're informed Limpopo people that by the end of the first or second quarter, this would have happened. When you find difficult, do come back to the committee. Don't go in your small corners, amend your APPs without approval. I remember there was an attempt, Chair, which we stopped. Don't go to your small corners and amend. Come back to the public and say, we had promised you this. We have not arrived. We think we'll do this to arrive. So that you avoid 2 things. 1, you avoid fiscal dumping at the end of the financial year. But 2, you avoid unnecessary expenditure. You incur unauthorized, fruitless, and you end up being called Komadlanga Commission. I pray for all of you, including myself, that when I die, may my name not be called in any commission of inquiry. And I pray along with yourselves. Because in the near future, Chair, in the near future, after Bomadlanga and others, there will be a commission of inquiry that deals with a lot of bulk projects that have been delayed or money is lost. So I pray to God that
put it on there.
Finds themselves in such a commission. I pray for you, Chair. I'm a man of God, and I like to pray. And I submit, Chair. Thank you.
I'm happy that you have changed. Yeah. But before I give Honorable Mate chance, I must also address you. The last person who's going to speak is Honorable Wilson. Going to be Mate, Honorable Marx, Honorable Mabuja, and Honorable Wilson. But Honorable Mate, allow me to say something. This man has just said I'm a atheist. We have a lawyer in us, 2 lawyers here. What are you just, yeah, I've just said here without contradiction on this public platform that Kinamu one oriented and understand the matters of God. But I want to tell you that communists and people who believe in God are the most trusted people because they don't steal public money. They don't come here and be in the oversight and do business with government, in department, and sit here in the sheepskin while they know they do business with the department. That's how communists behave. So you should be lucky to have one. Yeah, but I'm a student. I'm not one. What you said, but I'm root. Honorable Martin root. Yeah. Okay, I must leave it there and give you the platform. Take the mic, Honorable Mate. We'll do it in that line, as for sure you have heard me. But as I'm waiting, Honorable Member. I don't know if it is allowed, it's a parliamentary to call waiting publicly.
Thank you very much, Chairperson. And I think it seems like it's a norm that before we we get into issues, we must also confirm. I confirm that I'm a Christian, and with part of my 2026 New Year resolutions, the only time I missed church this year, it was only last week Sunday. So I worship at Alive Church. We don't judge. You don't need to wear a suit when you come there. So I'm inviting you to come and see me. And this is my Sunday to provide service. Thank you very much, Chair. But that does not, being a Christian does not necessarily take away my oversight responsibilities. Let me see. Because I don't remember in that sitting of the legislature us opening the thing with a prayer. So it means that I still have a responsibility to play oversight role. One, the issue relating to medical supply, Dr. Lukulane, the department is planning to have at least 78% at the depot level. And I would believe that the depot then distribute to your various facilities. So with that 78%, so we're simply saying that even this year, we will continue to have shortage of medication. Because we are not planning to have the 100%. We are still going to have at least 12%, yeah? 22% shortage of medication. And I believe that we're supposed to be talking about 100%. Why should I sit here and be part of the decisions that says, yes, we'll continue to have medical, what do you call, medicinal shortage? So I need clarity in that regard. Can't we do something somewhere, readjust something somewhere, so that because now it is clear that we don't have, there is objective and we must also have strategic objectives. Those things are different. Our objective is to ensure that we provide health services to our people. But our strategic objective is to ensure that we must provide quality and better healthcare services to our people. So maybe we need to relook into some of these programs and see where can we redirect resources to make sure that we have 100%. Because let's talk about infrastructure. Many of our facilities leaves much to be desired for. And when you look at the previous financial year, you'd see or know there was money used for infrastructure projects. But as to where, it's something that one cannot be able to pinpoint. But I know where I come from. That facility is something that even if you'd want to support government and take your wife for labor, you are not sure whether you'd succeed or not. Where you still have patients, people bringing water, and blankets for patients, HOD. And it's sad, where even if you decide to go just to a courtesy visit, but for the CEO and whoever that is in charge there, not knowing who you are, and allow yourself to be subjected to a treatment where patients, to a treatment to which patients are subjected to MEC. It's sad. Up until you have to introduce yourself after at least 2 hours. I went there, I was also subjected to, I don't know whether it's ill treatment or maltreatment, but any of the above. Up until I had to introduce myself. And the intention was just to see as many people in my block were complaining. And elderly people. And I saw it myself. Maybe we need to have, I don't know, it's just government is government. Because we don't have public or we don't have staff that wants to work, but we have staff that must come to work. You have seen, I hope you have seen the recent clip in one of the clinics in Lephalale, where patients were just queuing there from 5 o'clock up until 8:30, and they've never been attended by anybody, but people are in their offices. It's sad. Our officials in the Department of Health, they lack work ethic and morality. Now, Dr. Kwalan, I've seen something on machinery and equipment. Last year it was at 55 or 51 million, but skyrocketed to something, 100 and something million. And this is still the trend, which one would provisionally conclude that it is still going to skyrocket to above that. But when we have these big monies, but yet those equipments that we are talking about are not there in various facilities. As and when we procure them, where do we station them? I've seen there is something, equipment for Maputo Malaji, but they're there, those things. And they've been commissioned. So these ones that we've procured last year and the ones that we're planning to procure this financial year, where are we going to station them? Because it is really sad And you know, Chair, other issues that we wanted to raise, maybe this ones one would need to raise with the MEC directly. Yeah, because, but I need to put it, and I'm happy that this thing is now on public. It must be placed on public HOD. Things that are happening in that pharmaceutical depot, they are not pleasant. Very unpleasant. And we don't want to get deeper into the corruption that is happening there. We don't want to. But for what I know, what is happening there and what people are being paid there, it is not what is in the bid document. When people were employed there, as per the bid document and whatever, there were certain amounts that were committed. And now those amounts have been reduced into 50%. And you speak, you are shown the door. You question, you have been shown the door. So how do you then reduce salaries? But it's fine, it's none of my business. But I'm just saying that it shows that maybe we don't want to act where we need to act. A lot of things that have been presented here. It is not, you know, we understand. But if we are to do audit, because these are standard things that needs to happen. But if we are to do audit, you would find that the progress, instead of us progressing, we're basically regressing. The ambulance thing, you know, I don't know, maybe MEC, your department, you are doing as much as you'd want to do, but unfortunately you have staff members that are not willing to do what they must do. Because I'm made to understand that every year we procure, every financial year, we procure a certain number of ambulances. At a particular point, we should not be having problem with ambulance services. Because we don't need 1 million ambulances. But it's a question of laxity in the EMS. It's simply that. Because if last year you procured 50 or 54 ambulances, this financial year you are planning to have 154. The 2 previous financial years or 3 or 4 you have been procuring. But still, it's like we are not doing anything. That is my worry with EMS. These other ones, well, some would just have to see Chairperson. Some of the things, whether we raise them or not, I think from where I'm seated, it will be material. I'm just simply saying, you know, the issue of filling of vacant posts. I don't see anything that seeks to speak about employment of medical doctors. The issue of surgical backlogs, where a person can sit with a fractured leg for almost more than 6 weeks. The 11 million budget, authorist and Chichar Energy, the Oscar Pistorius thing. Orthotist and prosthesis. Every year there is budget, but I'm not sure whether do we have impact in terms of the backlog. Because I know some people, they've been on the waiting list for more than 4 years. There is a guy that we just assisted from Zone 5. He has been on the waiting list for more than 5 years. And if indeed we have allocated 11 million, I would tell you that at a private practice, you only need 110,000 for complete thing. And surely in government is going to be less. So we can be, with that 11 million, we can be able to cover as many people as possible. But what I have observed, Chair, is very simple. It's willingness to work. Go to any facility here. There is no willingness to work. We have ill-disciplined, stubborn, and arrogant nurses and matrons. Old order. That will be very clear. You have ill-disciplined, casual, and clumsy young nurses that do not necessarily understand why they are there. By Lord, but the beneficiaries of these programs, the poverty alleviation programs, where you just take people from poor families, you put them into nursing college, and from God, there is no will. And all these things, unfortunately, these are the people that must take responsibility. That is the unfortunate part. But let me say, I'm telling you, my sister, your nurses are not very terrible. Terrible. They are very, very terrible. Attitude, no compassion, no nothing. If Honorable Mabotja can tomorrow or Monday choose not to wear a suit and just wear something clumsy and go to Show Hospital without his glasses, I'm telling you, he will give you a call in 3 hours and tell you what he has seen there. They don't care. They don't care. Thank you very much for now.
Thank you, Honorable Mate. You just cancelled, since I came to the legislature, Honorable Marks have been saying the health department is dependent on the commitment of the staff there. So it means I must change that. Honorable Marks, you are on the floor.
Thank you, Chair. Just for confusion, it's Moss.
Moss, sorry, Moss. I work with both Moss and Marks, and they are from different political parties. So this is a trouble to me.
Thank you, Chair. Mine is also just mostly concerns. There's no direct questions. Although the APP contains some positives and good intentions with a budget that's been raised by 10%, I think the will lacks to still meet these targets, and underperformance still continues and the targets are not achieved. My biggest concern, if I can also hook on to Honourable Marty, is medicine shortages that still exist in hospitals, ambulance services, overall hospital conditions, infrastructure that's been long overdue, critical staff vacancies that we still see, posts that's not being filled, and accountability for the spending, Honourable Chair. I just really hope that this budget will address the long queues, medicine shortages, broken equipment, and poor maintenance that lacks in general in our hospitals. But like I said, I don't have a direct question, just a general comment. Thank you, Chair.
Thank you very much, Honourable Moss, for that. You are on the floor, Honourable Mabotja. Don't take away your class when you go there. Yeah, when you go to Seshego Hospital, you won't see.
Yeah, no problem. Thank you very much, Chair, and greetings, MEC and your team. Greetings, colleague. Chair, my view of the APP is that it is aligned with the MTDP, the Limpopo Development Plan 2025-26 to 2030, and the NHI Readiness Agenda. And I view the APP to be largely structured around the sector indicators, which are useful for national comparisons, but may hide Limpopo-specific operational pinpoints. Because our province, you'll understand, MEC, it's deeply rural, and it has got aged infrastructure. There are lots of medical legal claims, EMS distance, and so on. So, but before I then deal with the concerns that I have, there are just some few pertinent issues that I think we must just deal with. Some might not necessarily be within the APP. Let me see, there's this thing, 30 June. We all know what people are saying about 30 June. So I just want to check two things. In terms of your revenue collection or revenue enhancement, there might be people that are going to be affected by the 30 June issues that are part of the people that owe the department. So what's the take of the department in that instance? Number two is that there are some people that are complaining that those that are affected by the events that are said to occur on or before the 30th of June are saying that their jobs are being taken away from them. But on the same token, there are those that are saying there are people who have got very rare skills that we need. So, we don't want to find ourselves wanting chair when that time comes and people are saying, this one took my job, this one did what, and what. So, as a portfolio, I think we need to be better equipped to know that the department has this number of foreign nationals that are within the PESAL of the department, number one. And if they're there, we need to get substantive reasons as to why they've not taken a mate. They've taken, they've taken whatever they wanted to take. So at least if we can get a rationale behind that particular decision, because we are not operational, they are, they must give us reasons. And I think, Chair, it will be very helpful if we get such reasoning. Maybe 19. So before the end of the month, if we can just get that reasoning, because it's going to be a mess, I think. No, I mean, people will be saying, no, hey, this one took my job, it's not even from here, it's from where, you see. So here's a portfolio, if we can be equipped with that information, that look, we've got this particular people. The reason why we have DKT, I had Madlanga say, hey, don't make examples about me. So I just want to make an example about the MEC, where we have got DKT, Ubereka within this unit, and the reason why we have her, even though she's not from our country, is because she stands out. She's got 1, 2, 3, 4, and 5 that we don't have. It's a scarce skill that we don't have within our own province or our own country. So if maybe the department can assist us with that thing, and then can we understand the monies that are owed to the department? And then what is the strategy going forward? Because some of them are saying they want to be repatriated back to their countries of origin, but they owe us. So now it's a debt, it's going to be a bad debt that we are going to have to write off. So now, what strategies are we going to have going forward? Also given the latest constitutional court judgment against the Operation Dudula. So what steps are we going to have going forward? Now, Chair, the medical legal challenges are not only a litigation issue, but the governance and legal risk. So we see that the APP acknowledges medical legal claims as a major legal environment challenge and states that while some claims arise from lapses in quality care, many may be motivated by factors that are intended to drain the already constrained financial resources. And then the APP also links the digital health records to a better management of medical legal claims. You know, Chair, ever since we got here, we've been hearing stories of this people stealing files and so on and so forth. And we have, as part of our discussions with the department, or as part of avoiding these claims, you need to update your system so that they can be, you can close all the loopholes. You have identified loopholes, or a loophole is here and here and here. So I remember last time the issue was at CETA. They said there's a problem at CETA, and then we don't know how far that problem is. But Chair, for us to have better management of those claims, we would need to have a proper digital health system, record system. And I think we've explained much into that. And therefore, I'd also like to caution the department about just treating medical legal claims mainly as external opportunism. Chair, because, you know, if the department has got poor records, if the department has got poor recording systems, poor records often lead to cases being lost where clinical care was defensible. So you might have the best clinical care, but if your records are not in order, you are not going to, you are just wasting time. So the department needs to make sure that their recording chair is in order. The other issue is that the department needs to classify its medical legal claims. So once they are categorized and classified, the department will be able to identify the root causes of where these problems are emanating, and then how do they then deal with them. Chair, I'll move to program 8, the 350 completed, 350 maintenance projects. Chair, you know, I must commend you, MEC, this time. The presenter of the APP was very thorough and he touched the right spots. So, Chair, there's 1 billion that has been set aside for maintenance projects. But I want to raise my concern, Chair, that counting the 350 completed projects may look good, but you must tell us the highest risk facilities are being fixed first. We cannot concern ourselves about, we have painted the ward there, or we have painted the building outside, or what. But at the same time, neglecting theaters. We find that the theater doesn't have oxygen, and then those crucial things that are going to, you understand them better, but those things that are going to ensure that the lives of our people becomes, we can try to save it. So, now I want the department to report not only on the number of projects completed, but whether the top 20 highest risk infrastructure failures have been resolved. So that's where my interest is. And then, Chair, on the training of the 200 nurses, which is a positive thing, we must commend it. But are we training, having a placement plan, that we're training them? After training, they are automatically going to be absorbed by the system? Or are we going to train them and then they contribute to the highest number of graduates that are just sitting at home without hope because there are no jobs. So when you train these nurses, we must be told that there's a plan immediately after graduating or taking their oath there at the college, hack straight to work. Because currently, Chair, was sitting with a lot of doctors that are sitting at home, was sitting with a lot of graduates that are sitting at home. So we can train, but if we don't have plan of placing these people, then it means there's a mismatch in terms of our plan. So we want to understand, indeed, we are going to train and place these people. And then on the transformation of your procurement processes, there are targets that you have set, but they are below the targets. So we are saying you can do better. 0.5 for disabled people, it's actually an insult, MEC. We want to see you meeting these targets without fail. So I'm just making an example about the disabled people. Or you can't keep your percentages on 0.5, whereas the national standard is above that. So we are supposed to be told that we have even exceeded that particular number that has been set for us. So, Chair, the other issue is on what Brasai said, that issue medicine availability. We are currently being told about the 78% at the depot, 83 in hospitals, and so on. But can we be told when we are going to 100% HOD? When are we going to be told now we are here at 100%? Because we understand it's a distinction, but it's not the distinction that we want. So we are saying to you, we were thinking that you were going to tell us, or no, now our target is 100% and we are going to attain that particular percentage. Equally on the patient safety indicator, you are setting yourself a target of 90%. Why are we not going to 100%? Maybe if you can just take us through. So, Chair, let me leave my concerns here. I think the rest of them have been covered by my colleagues. Thank you very much.
Honorable Wilson, you are sweeping.
Indeed, I am. Obviously, a lot of my concerns have been covered by the colleagues who've spoken before me. But I have a couple of major concerns. And one is the APPs. Every single APP deals with a compliance issue. Your APPs only deal with compliance issues. There is not one APP in the entire presentation and budget that deals with issues that we have raised as a portfolio. Staff vacancies, no APP. Machinery and equipment shortages, no APPs. Yes, you have to meet. I mean, legally, you must meet the compliance APPs. They're there and they are there for a reason. And they are generally linked to an act or a resolution or something at a higher structure. But not at any point in the entire presentation has this department dealt with one APP around issues that we as a committee have raised on our various oversights, and that concerns me immensely. Because either you are not prepared or not in a position to deal with the issues that we have raised and the things that we have highlighted as a commission, or there are something you don't want us to see. And you don't want us to be suspect of you as a department, because the moment we start getting suspect of you as a department, things tend to turn a little bit ugly, and we don't want to go there. And I'll give you some, so let me take you through some of the things I've highlighted. And I've talked about APPs. Program 1, your budget is 309.1 million, but you're expecting a revenue collection of 241 million under Program 1. Does your 309 million budget include your 241 expected income? Or does it not? Okay, generally it does not. So where is your 241 million income going to go to? Exactly what is that going to fall under? Because we need to monitor that revenue as well. Under Program 2, and I have a problem here, and particularly around districts, you've given us a breakdown of where that entire budget is going to. But if you break it down, you've got a cost of employment, a COE of 19.4 billion, but machinery and equipment of 445 million. Now, I'm going back to where I started. We have visited the district hospitals. They are shocking. They are disgraceful. They are filthy, they are under-equipped, and they are understaffed. And there is no APP to deal with that. What exactly is this machinery and equipment, this 449 million going to? And for where? And why? And why is one hospital getting preference over another? We cannot monitor you as a department, and it is our responsibility to oversee your performance. That is what we do if we have got absolutely no information to work from, or if information is not clear. And this is where we're going to have to run into a problem here with the department on this one. On your conditional grants, there's a breakdown of whole sums. This grant is so much, this grant is so much, this grant is so much. Can we please have line items under those grants? If this conditional grant is 350 million, what are you spending that 350 million on that specific grant? Because how can we monitor your performance and where that money is going if we don't know where you're spending it? If you haven't given us something to monitor. EMS Program 3. MEC, you must expect this from me because I have been going on like a banshee about EMS for 3 or 4 years now on the condition of EMS. On the 24th of April this year, my mother died in my home. It took an ambulance almost 3 hours to get to us. She had already passed away when the ambulance arrived. Now, I'm not saying that that ambulance could have saved her. I'm not saying, but now I'm talking about the center, the CBD of Polokwane. It took an ambulance almost 3 hours to get to us. I am not saying that they could have saved her. She was ill. It ended up with heart arrest. I'm not saying that they could have saved her. But it took 3 hours in a CBD, almost 3 hours, to get an ambulance to my house. Excuse me, I think the urban turnaround is 30 minutes, or supposed to be. The crew arrived. My mother was already gone. I asked them why it took so long to get to us. And the answer was, ma'am, we only have 2 crews on duty today for the whole of Polokwane. 2 crews on duty today for the whole of Polokwane. Now, if you think that is acceptable, I would be very embarrassed, MEC. And I'm not speaking out of hearsay. This happened to me personally, in my own town, in my own home. They obviously could not take my mother away because she had already passed away. It took us another 2.5 hours to get AVBOB to come and collect the body. Now, I'm not sure if anyone else has had to face that kind of situation, but it's really, really heartbreaking when you are sitting with a person lying dead on your bed in full view of the entire family for hours to get assistance. And everywhere we have gone as a portfolio committee, we see ambulances. Man, we see ambulances. Many ambulances. In the clinics, in the hospitals, there are ambulances. And now you want to buy a whole lot more. But there's no crews. Why are you buying ambulances and putting in them in facilities when we know we do not have crews to man those ambulances? The crews are not there. They do not exist. We do not have a training center. We do not have qualified personnel. Surely, the money you want to use on buying new ambulances should be put into somewhere or into a program where we can train the crews. We have the ambulances. We don't have the crews. An ambulance is not going to drive to the scene of an accident or a home and resuscitate patients or rescue patients by itself. And that, for me, is extremely, that the budget is going on EMS vehicles and PTT, when we have more than we know what to do with and not one crew for them, upsets me and upsets me terribly. And this is why I say we have a problem with your indicators. Because your indicators are not showing us how the concerns that we have raised are being dealt with. And I wanted Program 5, tertiary hospitals. This is where we're supposed to expand, teach, train, and create first-class specialized care for patients in Limpopo. There's not one APP indicator. There's no APP indicator that indicates to us as a committee that we are going to reduce the backlogs of surgeries by 30%. There is no indicator there to say we have a backlog of surgeries of 12,000 and we are going to reduce it to 6,000. There is no indication there on how you are going to address the scan feedbacks. Mankweng Hospital, where people are being sent for specialized CT scans and everything. They are sick, they are sent there for scans, and the report, it is taking 6 months and longer. 6 months and longer to get the report back on the results of that scan. And one of those is a woman we are dealing with at the moment who has got cancer behind her eye. First of all, they have booked her for a scan 3.5 months down the line. She's got cancer behind her eye, close to her brain. The earliest scan, it's cancer. It could be terminal, but we all know what cancer is like. The sooner you treat it, the sooner you remove tumors, the sooner you deal with it, the better chance there is of a person surviving cancer. She can't even get a scan. And once that scan is done, it's going to take 6 to 8 months to get the report back on the results of that scan. So in the meantime, not a doctor, not a surgeon, not an oncologist, nobody can help her because they have no idea what they are dealing with. They don't know what the scan is going to say, and even when the scan is done, it's going to take another 6 to 9 months to get the results. I think in all likelihood, that patient could be dead. Because cancer you treat today, tomorrow, you treat immediately in order to give that patient an opportunity. And you wonder why you are sitting with medical negligence claims. Because if I was that patient, I would be in a lawyer's office already, saying that the Department of Health in Limpopo cannot or refuses to assist me, and as a result, I am going to die, and when I do, this is what my family is going to do to you. Where are the APPs? On the backlogs of surgeries, whether they be orthopedic, whether they be oncology, whether they be pediatric, whether it does not matter. There should be we should have a breakdown of the backlog of every surgery and what you as a department are going to do about it. We should be getting reports on the backlog of these scans, because that means that there is a backlog of specialists, and this is a specialized tertiary hospital. Why, and what are you doing to correct it? Program 6, Health Sciences and Training. Great, you're going to take an intake of 200 people in this year, training nurses. How many nurses are finishing this training this year? You haven't told us. We're intaking 200, but 150 are completing their nurses training this year. And of that 150 nurses, they are going to be placed here, 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 and here. There's nothing here. We're taking in 200. Whoopee-doo, so you should be, and we need them. What are you doing with the ones who are qualifying? How many are qualifying overall? How many will be placed? How many are we not able to place? Because that is just exactly where the Honourable Marty has just gone to. Is the treatment of nurses inside the hospital. They are either overworked, overtired, over-frustrated, and they take it out on the patients. I don't want to see an APP saying that we're going to get 100% client satisfaction surveys. Have you been in the hospitals? And I spend a lot of time there because I'm on this portfolio, where the nurses threaten the patients that when they fill in that survey, if they do not say everything is perfect on that survey, there will be consequences for them in terms of the treatment they are going to receive in the hospital. That APP means nothing. It means nothing. The health facilities revitalization grant, 662 million. Where are the indicators that show where this is going to be spent, what it is going to be used for, where exactly in the budget is that going to? We're not reporting on it, we're not getting breakdowns on it. The Maputo Malachi Hospital project, which we believe, or you led us to understand, was finalized a long time ago, in terms of OPD, casualty, X-ray, pharmacy, etc., are back on the APPs and budgets here. I don't understand why we were led to believe that that project is finalized. It also says that Public Works, sign off by Public Works and various other departments. Well, you've spoken to Public Works and they made it very clear they don't have any outstanding projects with the Department of Health, so why is it on the report? Who's fooling who, or who doesn't know what they're doing? MEC, your budget speech does not talk to your APPs. You said a lot of things in your budget speech that are not appearing in these APPs and budgets, and examples of those are things like the partnerships with the likes of Venetia Mine, etc. Those are things that should be showing here and they should be being reported on. They're not, so that there is a disjuncture. And there's no APPs on the reduction of medico-legal claims. We want a commitment from this department that the number of medical legal claims that we are being subjected to every year are reducing. not increasing, which is what they are currently doing. I'll leave it there, Chair. Thank you.
Thank you very much, Honorable Wilson and honorable members for the question, input, comments, and question of clarity. I have seen that no one of you have asked a question related to the experience you had at your visit to the pharmaceutical and the call centers. And in that day, I was in trouble because honorable member wanted to ask some substantive and management issues there while we were supposed to deal with the guys that were there. And my team is restricting me to say you must not go into the questions unless if you allow the department to do, because there is a way that will deal with it.
Just for interest.
That's it, yeah, I wanted that interest. I will start in Doug and end with you. But please don't go low.
I won't be long. Thank you once more, Chairperson. I said I'll leave other questions for other members, but I think there is this interesting one which the department is aware of, which is supposed to be part of the plans in terms of dealing with it. Like when we visited hospitals, we found that the mortuaries are having a lot of purpose barriers that are sitting there for many years. And some of our suggestions then was that can the department, because it's the one that is suffering, plan to deal with this problem and then build a municipality, if it is so allowed, because the municipalities are not coming to the party. But then they can have someone that they deal with in the municipality to ensure that these things are happening, and therefore try and deal with this backlog that are there in Bilavela Hospital, for instance, and I also know in Ilimo Hospital. I'm not sure if they have already dealt with that problem. And this is part of the things that we notice when we're visiting hospitals in our oversight. The other one is when we went to Waterbeck, you remember that we had to meet one person who is everything in the nursing college, and that Waterbeck Nursing College has closed. And there was just one person, and there is no capacity. And there's also, remember when we had a workshop at the ranch, there were issues around the licensing and so on, which could be withdrawn, and I'm not sure how far that is now, and whether that has been dealt with because of issues of capacity. St. Rita's, for instance, when we visited there, it's a similar situation where even the MEC visited, and there are issues because of capacity and the people who are dealing with the training and a lot of other challenges, and whether these are not supposed to be planned for in terms of dealing and addressing those questions that are actually the gaps that are there in training the personnel that we need to make sure that our hospitals are actually functional, and having nurses that have got the right attitude, gone through the correct training, and not take them through, where you find that you are in training, but you are, even before you reach your hospital, you're already demoralized. And by the time you reach there, and then your mind is not there to assist our people, but is there for now to do other things, and to react on what you have learned when you were in those difficult areas where the training was not up to standard. So the planning should be around that. I think I mentioned those two, the Waterbeck Nursing College, which is closed, and the EMS. Honorable Wilson is talking about these issues as well, which is very, very, very touchy. And where you find that our ambulances are standing there, but they have got no people. Whether we utilize EPWP is fashionable nowadays. You utilize EPWP everywhere, and whether now some of our ambulances are being manned by EPWP, I'm not sure. I'm just asking. And if so, I will also, in a way, to train those people going forward in job training and make sure that they actually have these advanced life support issues. And why can't we plan for that? I think I didn't go much. I felt that I've dealt with those ones which are critical. Thanks, Chair. I think that's where we'll end it.
Okay, thank you very much, Honorable Ndaka. Honorable Mate, you're on the floor.
Just too quick.
You can switch off your mic, Honorable Wilson.
My apologies.
Just too quick. The other one is information to your MEC and HOD. You know, I normally stay away from things that affects me directly. And I know raising some of these things, they always put other people into trouble. But either way, I'm going to raise it. You know, when the portfolio committee responded to your invitation, MEC, to visit the pharmaceutical depot, there was a staff meeting there before the visit of the portfolio committee. And staff members were strictly told not to say anything and not to complain about their experiences there and their salary reductions to the portfolio committee. If they do that, they must consider themselves fired. I'm raising it for your information, and I know it's going to put somebody in trouble. And I'll take responsibility for that person when he's in trouble, because already he's targeted. The last thing for interest, where are we with Veritas currently? Just for interest, for one to know. Thank you very much.
Apology. It was a nature's call that I have to go there. I miscalculated that Honorable Matu will speak for 1.5 minutes, but he spoke for 45 seconds. Thank you, honorable members, for your question, input, and comments with regard to the APP. There are a few things I want to say, but we'll end in the context of what Honorable Ngoyana have presented. I imagine if Honorable Speaker was not giving you clothing, what we are going to wear, Honorable Ngoyana. That is in a lighter note. But Honorable MEC, there is something that you needed to note that I meet in the portfolio. You should be uncomfortable when members think that anyway, we are going to raise the issue of recruitment, we are going to raise matters of infrastructure, we are going to make matter of recording, we are going to raise matter of digital Veritas. Anyway, the department is not going to listen. And they have no interest in attending. And of course, as a person who loves myself and have a reputation, I also have a problem with that. If members can stay with me in 2 years, and they tell me that in the past 2 years, Chair, that you are presiding over this committee, we have been asking this question all the time. We even said the department is the beginning of the year. Tell us what you are going to, what is your plan about HR? And the department refused, and I'm asking a question. What must we do? Where must we come to your portfolio? Well, to me, it's like, it's either must leave, ask to be shifted, because I'm incompetent, and so on. Because that's the question. In fact, this is a question I'm considering. To ask that I must not proceed with this work based on certain matters that are raised all the time, and there's no substantive and a matured response that will assist us to go forward. But let me, this was like we're in a break, commercial break. But this is what these members are raising every time. This morning when they tell me Honorable Levi is sick, when I was before the formal apology, I thought she's not coming because she's part of the people who tells me this question. I'm just giving examples for all of them as you see them here, who do that. I tell them, no, there are changes, since what, they say, aye, what changes? But I wanted for you to know the following. There is, and of course I'm reminded by the fact that there is a reluctant and bad attitude. There is a new trend, MEC, where, these are not questions, just for you to know, including the first one, where people begin to want to raise questions through the portfolio and problems, critical problems. Some of them, for sure, I just take it to you. I just hope you are dealing with them as they are raised. Because if you are not dealing with them as they come back, that's a problem to us. I wish you, once we tell you a problem, you will deal with it until finally it should not come back to us. Because now we even have people who want to make presentation about certain matter that they want to prove to us that things are not in order. And the official of the legislature, they are not also wired for us to respond. They are afraid they will use the law for us not to listen, even to listen to certain things. Well, I'm not that way. I'm just saying, maybe they are orientating. I don't think there is anyone who can stop me from listening to anything that I wanted to, in terms of my response, if people think I can do something. So far, I'm restricted, because from time to time I had this legal advice that I just listen and say, this is, well, I was in trade, we used to tell the lawyers when they give a pure legal opinion, say, give us an opinion that will assist us to our work. You will give us an opinion that restricts us. That's what they do, with your colleagues. They don't want us to hear other things. They also want us to listen to the department only. And there are a number of issues members may not know. There are so many that they wanted to do that, so that we clean matters. I said, no, let me hear, because they are not necessarily part of the mandating process that we needed to deal with. And they say, we can't listen to them. I'm going to do it. Later I'll ask the portfolio if any, but I'm going to listen to those matters so that I interact with the department knowing everything from below, from above, from beneath, and so on. So that we become complete. We must not be given half stories as we go forward. I think that's important I mention without asking many questions. I also wanted to be aware that we have observed this thing, that you have an over-reliance on the EPWP on a number of your work. Among the work is hospital food services and patient admin, particularly in records. The picture shows that you have no intention to change that. You are not going to change it. It's given in terms of 2.5 years experience, if that happened, because everywhere, instead of subtracting it, it is continuing to be added. And of course, I have asked this because it was asked about your plan to do the work. And I can't restate the question that we asked at the ROM platform, at the EMS call center that members were asking. Let me reserve that right. There is this rural health matters, and I'm not asking you a question. I want you to respond only to the question that we're asking members. That is continuing, and we are told that it's free, or there are voluntary people that are doing so. So I don't know if people who are doing that have seen us on live. There are people who are beginning to want to say, no, there's nothing free. And I don't believe them. But we'll discuss it the other day when we have an opportunity. For now, let's deal with the APP in contest, and we are going to say how we'll want to go forward after you responded to the question. As you go forward, what time is it now? It is 12:25, you say, and you have had members worried about the fact that in Program 8, is in all programs that we are going to speak to you after the meeting, that they want specific, they want how many projects for the year in the context of them making an oversight. I'm saying just to remind myself when we make conclusion, you may not worry yourself about it. I'm just saying that we will need certain baseline information which we will use to check other things. And this does not restrict you now from responding to the question that were asked. So that time I was asking you so that you are able to know what time is it, and you are able to, MEC, to respond if there is any of the question that want you to respond now. Thank you.
Thank you so much, Honorable Chair. I think there's a lot of questions that need us to respond. So if you allow me, I'll allow the team and I will come after. Thank you.
Thank you, Honorable MEC, Honorable Chair and members. Maybe just to say the other our team members will continue. Maybe just to start in the very last one so that it's not an issue that can come back. So Rural Health Matter, it's a project where specialists from private, specialists from universities, and our own specialists team up to deal with the surgical backlog that we have. We have a surgical backlog. One of the main reasons is that we don't have some specialties. Even where we have, they are not enough. I think we have reported many times that we do not have a limitation in appointment of specialists. We have funding, it's on the grant, but even though we advertise, we are not getting. One big example I can give is orthopedic surgery. Limpopo is highly a trauma province. Even if you look at Statistics SA, we've got lots of accidents, we've got lots of injuries, people falling from trees, and that has given us a big orthopedic backlog. So, and sometimes people are admitted with orthopedic problems in the ward, but we are not even able to reach them because of the life-threatening and life-threatening that comes in between, because the doctors will prioritize a person who is going to die if they don't operate, a person who's going to lose a limb if they do not operate. So that is one of the reasons. So those specialists who come, the department pays their accommodation, we pay their travel, but we do not pay them any money for coming and doing the operation. I think that is where it is. But the clients that we work on, it depends what their category is. Then they pay according to their category. If they are H0, they don't pay. H1, then they will pay a certain amount. If they have a medical aid, then we bill from the medical aid. So that is just a clarification on that one. And then maybe the next one that I will talk to is the issue to say, Chair, that we are not maybe listening to the portfolio committee because the APP does not reflect the issues that the portfolio committee has been raised. There are 4 indicators that reflect that already. Program 8, infrastructure, that is one area where the portfolio committee has been coming to us. So the entire Program 8 it talks to. So what we will do, we do have the annual infrastructure plan. I think we should share that with the portfolio committee so that they will see where is the plan, which facility are we going. But that does not cover the maintenance. These are the breakages where things have broken, the leaking, it will not be there. But each and every hospital does have its own maintenance plan. that then covers those issues. So we will share that document. And also, for all the grants, all the grants are approved at National Department of Health. They are approved on the basis of a business plan. So we will share the business plans for the grants, because the business plan then goes into details to say this amount is for this amount is for this. I think that will also assist. And maybe the last one, the issue of recruitment. So for the past 2 years, we have been having a recruitment plan for each year, and it is approved at the OTP. Even this year, we have an approved recruitment plan from Office of the Premier. So it has 652 new posts that we are supposed to fill this year. And I think we will also share that plan so that the members can also note what is the funding. And the recruitment plan normally is based on the available funding and then the priorities. The other thing is that for the past 2 years, we have been approved to fill all the attritions, meaning we can't get worse than what we are in terms of the staff. So if we lose a nurse, we are able to replace. If we lose anybody, we are able to replace. However, for the backlog of the vacant position that happened, the years that we were not being allowed to fill, we are not able to fill those unless we get additional funding. So this is why when we looked at the available fund to say, while we are slowly but surely, little by little, going to start to improve our recruitment, let's work with the EPWP, because with EPWP, you are able to take one post and then have a number of people who can close that gap. It was a measure of closing the gap. And then the people that we are losing, we advertise those posts. Unfortunately, because we don't have a lot of funding, it's like a drop in the ocean. You don't see that we're actually even making an effort to improve the positions that we have. So, but what we are doing, we are going to ensure that where we are in terms of the full-timers, when we get additional funding, then we can, according to the priority, then we will start to improve on those areas. But the attritions, 100% we are allowed to fill, so we don't have a challenge with that. But I think that is the process that we will continue to do. Maybe a quick one. Again, I just wanted to deal with the quick ones. A pauper's burial, Honorable Mudaka, what happened is we have escalated to the office of the MEC. She has also escalated to the MEC for Coxter. So we are dealing with that matter in terms of the municipality coming on board to assist us to solve that problem. We can also report the issue of the Waterberg Nursing College. It is open, it is operational. We have admitted new nursing students who are doing midwifery, 167. So it's 92, those who completed their nursing training. They need midwifery so that we are able to employ them. So plus we added 75 on top of that. So we've got 167 new students who have started midwifery course this year. It's a 1-year course this year in the Waterberg campus, but they are rotating throughout the entire province. And the students that we are training each and every year, and the question is when they finish, do we have a placement plan? We do not have, because it's linked to funding. However, what we are doing, because the recruitment plan allows us to recruit. So we are looking at those who are retiring, those who are leaving. Every 3 months, we are now, I just got a list for the last 3 months. We are going to advertise the post. So when those people finish, then every 3 months as we advertise those who are retiring, then they will be able to come in, because that is the funding that we have of the warm bodies that are in our system. Without additional funding, we can't bring in new ones. So that means those who are leaving, then we'll be able to replace using those that have qualified. I think the APP indicators is the program 8, is the program 6, is the program 3, and the program 7. Program 7 speaks to medicine availability. And one of the concerns that was raised is the issue of saying we are targeting 78% and 80% and not 100%. So this is the depot normally. It's a transit system for our primary health care facilities. So as medicine come in, it's supposed to go. That's why the target for PHC and for hospitals will be higher. The medicine must be coming in and moving on. So it's difficult to put it, but we have a limit to say it cannot go below this, because if it goes below this, then it means we are going to run short, because we are always ordering. It's a belt. As we order, as patients receive. And also some medication don't move faster as well. So you also don't want to order a lot of those, because then they will expire and you lose the medication. So we use the guidelines that we received from the people dealing with pharmaceutical and national to look at that. Where if the medication is low and it creates a lot of shortages, it's at facilities, and that's when we know we are having a challenge. But as we continue to improve the stock, and the stock is also affected by internationally, how the medicine comes into the country. Around April, we didn't have certain medication in the whole country because it was not coming through. And nationally, it's always monitoring those medications to say there are areas and looking for alternatives to give us those. I think I will stop here and come back if some of the questions are not attended to by each and every area who has to deal with their areas. We'll start with CFO.
Thank you, HOD, honorable members and MEC. On my side, there were quite a lot of comments that were raised. However, there are two issues that I identified out of those issues that were raised. I think the first one, it was the matter which was raised regarding the appearance of our institution as to whether in the current financial year we have provided the budget to cater for that particular project. And the answer is yes, we have. We have provided almost 100 million, wherein there are also 2,000 EPWPs that are targeted, that are, at this point in time, I think DDG Mawasha will talk to as to the progress in terms of the appointment. We have also procured the tool of trades to the value of almost 17 million, which we have already paid at this point in time. If you could just check around our institution, you'll find that they've got the basic, tool of trade like the lawnmowers, all those things that makes our life easy. And we are now moving to a point whereby soon the DDG and myself, we will be coming up with the way in which, our institution will look like when you enter our institution. It is something that I believe the MEC might have spoken about at some other areas or platform, but it is deep in our hearts that it should be like that, so that our patients, when they enter our institution, they should have that confidence that even the care that they are going to receive will be, of that standard that, appears on the outside. That is the first one that I felt that I need to talk to. The second one, it was the issue of machinery and equipment, where the budget has tremendously increased, from the prior financial year to the current financial year, from 385 to 610 million. And there was a question to say, where are these equipments that we are buying? Definitely we do have, the information, and we would ensure that that information must find its way to our portfolio committee in order for them to be able to play their oversight role. Secondly is that if you look at the current financial year, we have prioritized areas such as, procuring equipment to replace the old one, like the X-rays. There are so many old X-rays that are no longer, compatible with the new technology. So those X-rays machines are going to be replaced, all of them, at this current financial year. The dental chairs, we are moving towards getting the new advanced technology dental chairs as well. So we have made a point that we provide enough budget in order to make sure that our people get the services where they are, so that they shouldn't be these, services that are provided at Polokwane. You find that our patients are moving from as far as Wembe and stuff like that just to get a scanner and all those stuff. So those are the issues that we are moving forward to do. That is why the budget has been increased, and intentionally made a point that we make a point that at the hospital level, we do not have challenges of equipments, because whenever we've got challenges, definitely that is where the problem is. Let me allow...
Thank you, CFO. Thank you, Chair, MEC, and members and my colleagues. There was a comment on, or advice on medico-legal matters. I confirm that the matters are indeed categorized, and that enables us to focus on problem areas. For instance, we are highly focused on obstetrics and gynecology, as well as orthopedic matters. We are also able to zoom into specific institutions where the statistics show quite high numbers. For instance, we've been focused on Chilizini Hospital, and we're still going back there because the numbers there were pretty high. We're there with our specialists, analyzing the cases, making decisions about settling some of the cases and determining those that must be defended. But we also have set up a committee that discusses the substantive issues around these matters, root causes, and we're addressing those. One of the interventions we'll embark on now is on staff attitude. That was raised by several members here. We are discussing a program that we will roll out to address professionalism and transformation of the manner in which we relate with patients and families. We've also done some benchmarking on the health information system. We're finalizing a report on that. We did some benchmarking because we got to know that some departments of health are developing systems internally. That is after the struggles we've had with CETA. So we were looking at what they are doing and what we can copy, and we then finalizing a report, and a decision should be taken in the next executive meeting in July. And when that is done, then we will roll out. Depending on what the decision is, it will inform the procurement or sourcing strategy. There's also a plan we are implementing, member, around grounds. It's a comprehensive focus on all of the hospital grounds. The plan is approved by the executive. We are implementing that. We're just ran into a problem that the panel of contractors that we had, the contracts have run out. There isn't sufficient time for them to conclude. So we are busy now with specifications. Unless a new contract comes into existence, it would assist us to move faster on the areas that could be covered by the scope of the contractors on the panel. There was a question on Veritas. Veritas, any one of these people or the department and all of that, we can make that determination. I think these are the questions or comments that I picked up. Thank you.
Assist us as we plan further, and maybe just talking on the issue of a backlog in terms of our facilities and clinics. So the clinics were being built since 1994, and a number of clinics were built since 1994. Only in 2018, the department put a moratorium because of the amount of money that is there, to say let's focus on refurbishing the old ones so that they don't totally disintegrate, like the examples that were given. This moratorium has been lifted this year. So the clinics that were being built between 2018 and now were those that were done by the National Department of Health as replacements, as well as the mines that were giving some of our facilities. But just to give an example, the backlog, how huge it is. We have assessed our mental health care facilities. They are not in a good state. We have assessed them to see how much money we will need in order to make them to an appropriate state, to discover that we needed more than 6 billion. But for the entire province, for maintenance and refurbishment, we only have 1 billion. So it's a matter of funding what we have slowly and systematically. We'll utilize it, including when we are finalizing now the master plan, 10-year master plan for the entire province, which is going to assist us to guide to say, for this year, the planning is starting because we have been pronounced that we are going to start. That master plan, the team is just finishing that work, but before the end of the year, the planning would have started, and we will say, indicate where in terms of that master plan. So I think the rest were comments to assist us. Oh, yes, so the CT scan availability, it's linked to two issues. The first thing is that you only have limited number of specialists to do the reporting. So what we did now, in order to overcome that challenge, we have now appointed a service provider to assist the team, the internal team, to try and process the reporting, because it is correct that cancer is a serious illness and it's a death situation unless it's attended timeously. So that service provider is now engaging. I think in the next sitting we'll provide the statistics of how far we are trying to clear that backlog of the reporting. So it is indeed a challenge, and it's linked to the availability of specialists in radiology, and that is our challenge. So the service provider is augmenting, and we are hoping that that will also reduce and improve the lives of the people that we are saving, so that they get the treatment on time. Maybe lastly, MEC, if you allow me. So with ambulances, that year when we purchased 500 ambulances at once, I think prior to that year, the committee members, I don't know if they were there, we were literally on our knees with the ambulances staying in merchants because they were old, dilapidated, over 300, 400 kilometers. So that year when we purchased massively, we didn't cover all our EMS stations. So there were stations that were still utilizing the old ambulances, and still they were still having the same challenges. So what we are doing now, we have been purchasing to try and come up to the level that is acceptable for all our ambulance EMS stations to have adequate ambulances. Once that is done, now we are also working together with Treasury, a replacement model, because those that were bought in 2022, already they are starting to reach their sell-by date. So we are working on a replacement model such that when one ambulance reaches its date, then we will be able to replace. So that's what we are working on, and I think some of those machinery and equipment is still going to that replacement model. So we are finalizing and also working on a replacement model for all our ambulances going forward. Thank you.
Thank you, Chair. I just wanted to start by saying, Chairperson, to honorable members, that as a department, we take the role of the portfolio committee very serious, the oversight that you are doing. Hence, most of the things, Chair, that were brought to us by the portfolio committee through your reports and even the calls that we are getting from members of the portfolio committee, we do attend to them. And Chair, I can personally say in some cases where you go to facilities that I've never been to and you share the challenges, I would make it a point that I personally go there as well to go and see what is happening so that we assist. I just wanted to clear that as the department, we have done a lot. I think in our previous sitting, Chair, we were actually commented by this very same portfolio committee to say they've seen improvements with the challenges that they've brought to us as the department. So we are just want to make it clear that we really respect the work of this committee. That is why we'll continue to try and have programs to address the issues that are raised by the portfolio committee. And Chair, the issue of my budget speech vis-a-vis the APP, Chair, the budget speech is actually talking exactly to our programs that are here. Maybe it would be the issue of unpacking, as the HOD has said, but when we spoke of our maintenance projects, our infrastructure, the equipment that we are going to buy, the vacancies and everything, it talks to the plans that we have as the department, and we'll continue to ensure that we follow up on all the things that we have committed to, that they actually happen, Honorable Chairperson. The issue of the infrastructure, the maintenance projects that were happening, the 350 that were completed, in terms of the value, as Honorable Mabucha was asking, or it's not just about saying we have come, we paved the clinic when there's something that needs of much more importance or that needs urgent attention. What we do not sit as a head office to decide, or this is what we are going to do. There's consultation with the facilities themselves. They make submissions to say, as the department, we know we've got this budget, we can't do everything at once. What are the pressing matters in the facilities that we can deal with now? And they submit that, and that's what we start with. That is why I would say we're here, we decided to paint the walls because of 1, 2, 3. After that, we would come to the pave. We check, or what is it that needs our agent attention, then we start there, but with the plans of saying when we get more funds, we'll continue to deal with the other processes. And yes, I agree with the portfolio committee chair to say, in terms of how our facility looks, talks to the patients to say, indeed, when I'm here, I will be assisted. That's why we are intensifying this issue, maintenance, but also we are saying we cannot maintain alone and you find our facilities are dirty, because we do not have staff or we do not have personnel that is cleaning the facilities. Hence, the 2,000 EPWPs that they were spoken to here by the DDG, that we are planning to have an additional 2,000. The 2,000 EPWPs that we are talking about, they're not the ones that are advertised now. We are planning on having an additional, that will then utilize the equipment that CFO was talking about to say now. Previously, would say there's big grass in our facilities, we need people to come and cut, and there will be charges and everything. So now we are saying let's have our own tools and get EPWPs be spread around our facilities to ensure that we won't be having a complaint of saying, hey, we've seen snakes because the grasses are too long and all that, but we want to see our facilities being cleaned both inside and outside our facilities. The issue of our paupers burials, Chair, yes, the matter has been escalated to me. I'm in communication with the MEC of Cockstar. I know now that there's a letter that has been written to all the local municipalities, but also we've agreed that we'll also be calling them into a meeting so that we can be able to have a plan on to saying, how do we then assist one another moving forward to say we don't have to see having so many bodies that are lying in our forensic mortuaries without being buried, so that it does not interfere with the service that we are giving to our people. And the rest, I think the team has dealt with, but we are saying even in terms of the equipment, When we buy equipment, we buy because there's a need. We send to our facilities so that we can improve the services that we are giving. Same applies with the program that HOD has explained of Rural Health Matters, which is very much helpful when it comes to the surgical backlogs that we are faced with. What we can say to the portfolio committee is that we continue to work very hard with the little resources that we have to improve healthcare services. But obviously, there would be disappointments where you'd find we still have those attitudes from our staff, where we'd find that there are people who do not want to work, they come to work. But for us, when we get these reports, we have our processes that to deal with those people within our facilities. And that is why when we go visit facilities or when we talk to people complaining, to say it's good to complain. And when we complain, we don't just generalize, but we get to know who are we talking about so that we can be able to address that person. Because if we say, I went to Mankweng, for instance, the staff there is not good, we need to know who is that person so that we can be able to address it. Because it's very much painful to get a call to say, MEC, I was at this facility, I was not assisted, somebody was rude to me, I left. So we always say, don't leave, call us where you are so that we can be able to address the issue, but also ensure that you get assistance when you are in our facilities. Thank you very much, Chairperson.
Thank you so much, Honorable MEC and your team for the attempt to respond. I think we should close this part, not the meeting. As I'm going to say something, we should not try, we're still going to close, but I needed to say something. The first thing, which is unrelated to any discussion, is that, which I'm raising here, because it's a matter that requires the department to note and see if they can assist. There is a man called Isaac Madibana, who is popularly known as Benjamin. He's a musician, Honorable MEC and HOD. Stay in the area of Blowback, there at the border when you go to Malakwen, in a village called Gideon, under Hoshimalwo. He's a singer, he's no longer seeing. His eyes cannot see. And the nurses at the clinic advised him that, no, it may be, I don't know what you call cataract, whatever. And of course, he remained with the voice, he's helpless. I don't know if you can reach out or make reference that he get assistance. I wish you can do so, and the Hoshi there will be very much happy, because he sent people by wheelbarrow to get him to come and sing at the traditional meeting when for entertainment. Some people knows him here for sure, Spencer Man. Yeah, coming back to the work, there is a matter of your, and I'm not opening the meeting, I'm just closing this part. Okay. Yeah, you're on the floor.
I wanted to congratulate the MEC for responding to the Mankweng call that I gave. I received a call from Johannesburg about an old man around Mankweng who could not be operated on her eyes, was given a date, but was told he would be given a date, and was not given a date for a very long time. And then they complained to me, and I passed it on to you. And then they then came back to me. They wrote a message. I wanted to read it to say thank you very much. They have responded quickly, and that the old man has been operated on the very same eyes issue that you're talking about.
Oh,
so these are on a positive note that you are at work. Thank you very much, Honorable.
Oh, you are saying HOD and MEC may have to reach out to Mr. Varki Isaac Kwajongona Madibana, who's known as Benjamin. We have the same problem, and they can assist. Yeah, thank you very much. MEC, the Department of Public Works, they say they no longer deal with your project. if that is true, for sure you may have an implementing agent. For sure, at an opportune time, you will let you will clarify that with the portfolio. I think we have dealt with all matters. May I raise the following just to show that the chairperson was listening? The HOD, in the context of what Honorable Ngonyana have done, so that we have baseline document that will assist us and make sure that there is transparency from us, so that we must not surprise you, because we have that capacity, MEC, to surprise you and demand certain things that you don't know, to protect ourselves and our integrity. The HOD have mentioned the following: the recruitment plan, just for us to be able to relate to it in terms of accountability, the infrastructure plan, the grant business plan as well, which deal with those matters. Maybe I must say the other thing, we will prioritize them. As we mentioned, what you mentioned, also mentioned certain things that we needed. Because other thing that you yourself mentioned is about the risk that you identified, and we may want to have interest with regard to how are you going to deal with them, to address them. The other thing related to how are you going to address the unwanted and unawarded pharmaceutical items that were mentioned. We'll clarify them properly in black and white. We will come to you as well with regard to how your plans to improve the capacity and performance of nursing colleges, all of them, including Waterberg 1, the EMS college. We have observed what honorable members said about what is not appearing in the PP. We'll magnify it so that it may need, you can find that you just need clarity. If it's not clarity, you will respond appropriately. What members have observed with regard to challenges of maintenance and repair when they go for oversight, with what they see and they ask, and the institution cannot budge, but they are meeting a budget that mentioning that they are going to be done, then we may need to want you to, particularly on medical equipment, to want you to clarify us. We talked about staffing gaps, and we got the answer. We'll still redo it so that we have a baseline document. And clarity on specific budget items that was said regard to program 4 here. And of course, members were also interested on why you have made adjustment and what were the reason and so on. We will clarify it simple way in the context of performance management so that we can see that. EMS vacancy measures and how you going to improve functionality and the end user experience of the you call it CAD or CAD system. And I was listening to her about that, about the experience that we have, and I think it's a matter of continuous improvement, but taking the experience that we get into consideration as you go forward. It's important that we do that. The measures involved or introduced, whether now, even if it's the previous one, so that you place them with regard to an ongoing debt recovery challenges that are there. And I'm mentioning this way because you should not say you don't have the present one, even if there is an existing one, so that we are able to let you account properly, HOD, and see I got the attention of the CFO with regard to that. This includes procurement plan for the current year and its budget allocations. Well, there was an issue related to, which I call it contradiction, related to the maintenance of the health centers and clinic. I mentioned it earlier, maybe I must jump it. Yeah, I think I said I'm mentioning them so that Honorable Mdaka will understand I was also listening. But the team will simplify the work, starting with what you have mentioned, so that we can assist us to have a baseline document that will work on them to look at your work from performance perspective, because we don't have different work from what you are doing. The nature of our work is, the source of it is what you say you said you will do. So we are contributing to make sure that you do that. For in case if one of your team or your department, your section is sleeping on duty. So you should be understanding us in that regard so that we are able to work together. Honorable Mabojabar, the next commission, the same as Iya Madlanga, will be chaired by you. Please prepare yourself so that you do better than Madlanga. The other commission have disappointed us. It's only Madlanga that is giving us confidence, because after the city, a person is going to be arrested. Yeah, we are at, thank you very much. We are at item number 5. Can I check with my team if there is any announcement? I think we are going beyond your time, MEC. I hope they are speaking to you, your people, the other side. Is there any announcement you are making?
Yes, Chairperson, we have arranged lunch and everyone is invited to partake. Thank you, Chair.
Thank you, that one. Yeah, I think the meeting is adjourned. Thank you very much, everyone.